I created a quick doc here that helps you evaluate your patient if you come across hyperkalemia on blood work, which happens pretty often. So I break it down into 2 steps. The first step is to rule out spurious and iatrogenic causes. So spurious is usually things like lab error or things that happen during sampling. So the highest amount of potassium that you have in your body is all inside of cells. And platelets, when they clot, release potassium. So potassium goes up. So if you're collecting serum and you're clotting your blood in order to collect that serum and you have a really, really high platelet count, then it can raise the potassium. But usually it only raises the potassium when you have platelets in excess of 1 million. Then you can have potassium that leaks out of red blood cells if you have hemolysis during collection. We all know that happens sometimes. And then Asian breed dogs have really high potassium in their red blood cells naturally. So sometimes you will find that you can have like a really high potassium in your patient, and it happens to be like an Akita. And if you do see that and you suspect that there is hemolysis because the serum looks a little pink, you should spin it down and, well, not spin it down. You should try to either redraw carefully, or you can actually try to run the potassium off of plasma, because then you won't see that spurious cause of hyperkalemia. And then finally, I think we've all, or maybe, if we haven't seen it happen, we've heard about it happening, where if you fill your purple top tube before your red top tube and you accidentally collect some of that EDTA in the needle, and then you move that needle into the next tube, you can actually put potassium EDTA in your blood sample, and then that will measure really, really high. And typically you'll have like a patient that's totally normal, but you're reading a potassium that's consistent with a patient that should be dying. So then you'll think about, well, that's probably wrong. And then maybe you'll ask if the purple top tube was filled first, or just go straight to redrawing and rechecking. So then if we come over here to iatrogenic causes, these are causes that happen from, treatments that we're giving our patient. Are you giving fluids with a lot of potassium in that? So check that first. Are you giving ARBs or ACE inhibitors? Those will decrease your aldosterone, and that will cause hyperkalemia. Do you have a potassium-sparing diuretic on board for your patient? Did your patient just get chemo, and are we worried about tumor lysis syndrome? That's pretty rare, but those are all the iatrogenic causes. Okay, so let's say we've ruled out our spurious and iatrogenic causes of hyperkalemia. The next thing, step 2, is going to be check for azotemia in your patient. Now, let's say our patient is not azotemic. Your next question is going to be check their BG, make sure they are not hyperglycemic. If they are, you're going to want to check and see, could they be DKA? DKA patients are frequently mildly hyperkalemic, and this is a way that you can remember this is you know that you use insulin sometimes with hyperkalemic patients, because insulin helps drive the potassium back inside of cells. So if you are depleted of insulin in a DKA patient, then they usually have high potassium. Now, let's say your patient is not hyperglycemic, then you're going to want to say, check for cavitary effusions. Are they third spacing? Pop the probe on them. Take a look around, see if you see any free fluid. If you do see free fluid, it's called a third space effect happening. And the reason for hyperkalemia with third spacing is because you are losing all this fluid volume from your vascular space. It's being basically deposited into either your belly or your chest. And as a result, you are fluid depleted, and less blood is being presented to the kidney. So therefore, less potassium is going to be dumped into the urine, and your potassium can rise. Let's say there is no cavitary effusion, then pay attention to your CK. Is your CK high or low? If your CK is high, you're going to want to think of things like, could there be cell necrosis from either ischemia, like a cat with a clot, or something like exertional rhabdomyolysis. That happens sometimes in dogs that are very, very active. Now, if your CK is not high, then check for whipworms. That's one cause of pseudo hyperkalemia. Now, let's say that your patient is azotemic. Then the next thing you want to do is think about your physical exam. Do you remember whether you palpated their bladder? Go and palpate their bladder. Is their bladder large? Then you're worried about a urinary obstruction. And that can cause the potassium to go high quickly. We all know about that. Is their bladder small? If so, you're going to do your cavitary effusion check for ascites. You don't see it, then you're thinking of things like acute kidney injury because they're azotemic, and that can cause potassium sometimes to go up. And then it's more likely to go up with acute kidney injury, and then also Addison's disease. So you may want to check and do a baseline cortisol or just go straight for a stim. And then finally, if you do see ascites with a small bladder, then you're going to want to check, could they have a uroabdomen? And the way that you're going to check that is you're going to get a sample and you're going to run the creatinine and the potassium off of that ascites or fluid sample.